Hi everyone, thanks for joining us for another of the SimSip webinars. So today we are going to be looking at a very different topic from the last couple of webinars that we've had, focusing on bispecific T cell engagers. So as you should be aware, we are going to be recording this session. Everyone should be muted. But if you have any questions, obviously engagement is great. Please raise your hand or utilize the chat feature. So if you could move on to the next slide, Xingwen. Hi, thank you. So today's speaker is Inran. She's a principal scientist of clinical pharmacology, modeling and simulation at Amgen. And she works as a mechanistic PBPK modeler and as a global clinical pharmacology lead for oncology, as well as rare disease therapeutic area programs. She's previously worked at the FDA as a biopharmaceutics reviewer, and her training is as a pharmacist and in a PhD in pharmacology. So we've asked Xinwen to do a presentation based on her publication earlier in the year, and this one focuses on using PBPK, but also looking at the kind of bispecific T cell engagers, but one other interesting kind of angle is looking at adult versus pediatric. So without further ado, I'll pass over to Xingwen, and we look forward to your talk.
Thank you, Oliver. Thank you, everyone, for joining today's seminar. So today I will introduce the development of this mechanistic PBPK platform model for bispecific T cell engagers to guide adult and pediatric dosing through both intravenous and subcutaneous administration. So first, I want to give a brief introduction of bispecific T cell engagers. Some of you may already be familiar with this class of modality. This is a very promising class of therapeutic protein that have actually revolutionized the treatment paradigm for oncology indications across both liquid and solid tumors. There are currently around 9 BiTCEs approved by FDA, and the first approved, most of them are actually approved within the last 3 years. Over 600 BiTCE candidate modalities are currently under development. Amgen is one of the pioneers in this field, and we have the first-in-class FDA approval of Blincyto and also the recent fresh approval of tarlatamab for extensive-stage small cell lung cancer. What's showing here are the structures of the three generations of BiTCEs. So the left side is showing the first generation BiTCEs. They generally comprise of two flexibly linked domains, with one domain designed to bind specifically to the CD3 receptors on the T cell, and the other domain bind to the tumor antigen on the tumor cell. So by this way, the molecule can bring a patient's own T cells and direct them towards the cancer cell and stimulate the efficient elimination of tumor cells by T cell. So these first generation of molecules usually have relatively smaller molecular weight, around 55 kD, and there is no Fc domain. So therefore, they generally exhibit relatively short half-life, around 2-3 hours, and currently are only approved for continuous IV infusion administration. A representative molecule in this first class is Blincyto, the CD3 and CD19 for acute lymphoblastic leukemia. The second generation of BiTCEs have included the Fc domain. So with FcRn-mediated drug salvage, they have relatively longer half-life, allowing for IV dosing. representative molecule in this class is the recently approved tarlatamab from Amgen. A third generation are the full-length bispecific antibodies. They also have relatively longer half-life and allows for IV dosing, and some of them are actually approved with SC administration. Most of the recent approved bispecific T-cell engagers are from this class, are full-length bispecific antibodies. So the development of BiTCEs are rapidly evolving from the conventional IV dosing to more convenient SC dosing, and also extending beyond adults to also benefit pediatric patients. So about PBPK to support pediatric drug development, over the years, we have seen increasing use of PBPK models to support the pediatric drug development. However, most of these applications are still in small molecule field. For large molecule, there is still like less cases, but this is actually a rapidly evolving field. This is likely due to the relatively better understood ontogeny changes that contributing to the small molecule admin processes. For example, the drug metabolizing enzyme ontogeny, drug transporter ontogeny, all of these we have relatively richer literature and research on them. And for therapeutic proteins, there are still limited data, but like I said, rapidly evolving. So in this work, our goal was to develop this mechanistic PBPK platform model to support not only adults, but also pediatric development of the BiTCEs through both IV and SC dosing, and also with the capability to support all the 3 generations of BiTE molecule. So this slide describes the process of how we developed this mechanistic PBPK platform model. So as a general, we started with the adult PBPK platform model because this is and through IV dosing, because this is where the richest clinical and also preclinical data set we have. So once we have the model, we run model validation using the BiTCEs of different structures from all the 3 generations. And then we proceeded to add the SC dosing parts, run further model validation using the internal data set. And after that, we have included the pediatric ontogeny parameters by using the SimSip pediatric database, and also with additional modality-specific ontogeny parameters like the CD3 and tumor-specific antigen and epsilon, etc. And after that, we validated the models, the IV dosing part using the data that we have. And then we proceed to add the SC dosing part to the pediatric model. So this is a general process. And this is a general structure of this PBPK platform model. So we used a full PBPK model structure with around 14 organs for distribution and elimination, and also incorporated a mechanistic absorption structure for the SC dosing. So yes, let me break down. So for modeling the SC dosing, we actually used the mechanistic SC absorption model built in within SimSip. So after the drug is administered to the subcutaneous fat layer, it is assumed that it will form a SC depot within the interstitial space. And then due to the osmolarity differences, the drug will slowly diffuse to the surrounding tissue, and then gets absorbed through either, but mostly through the lymph flow, lymph collection, back to the peripheral lymph node, and then to the systemic circulation. And some drug, especially the first generation, we allow them to be absorbed through passive diffusion. This obviously is a relatively smaller amount, and that will directly goes to the vascular space and goes to the systemic circulation. So the first pass extraction at the local area were assumed mainly through the lysosomal degradation, where the drug was taken up into the cell and then goes through catabolic clearance. So we used some like internal available data set to parameterize this process. So for distribution, this model, like I said, we use the full PPK model structure, and it includes around 14 organs interconnected by lymph and blood flow. So within each organ, it's further divided to 4 subcompartments: the vascular space, the endosomal space, and interstitial space, and intracellular space. So once the drug goes to the vascular space of a specific organ, it will further penetrate into the interstitial space through a 2-pore model, which assumes that there are some small pores and large pores on the capillary structure. And so the drug will pass into the interstitial space through either passive diffusion or through convection of the lymph flow. The drug can also be taken up through the non-specific float phase pinocytosis into the endosomal space of the cell. And then within this space, it will further go through the FcRn-mediated drug salvage. This is mainly for the 2nd and 3rd generation of BiTE with Fc domain. And for 1st generation or the rest of the drug, they will further go through catabolic clearance. And by this, we gets eliminated. So for metabolism and excretion, there are mainly 4 pathways we have considered. So first pathway is obviously the non-specific catabolic clearance pathway. And the second pathway we have considered is the target-mediated drug disposition. And in this part, we have used the CD3 as a primary target. This is because, well, first of all, CD3 target pathway is like a common pathway for a general BiTE, and also data have shown that like by analyzing the PK for some BiTE TCEs, the time varying component in their clearance tracks with the observation of CD3 T cell dynamics. So usually after BiTE TCE dosing, we have observed the decrease of CD3 T cell in the systemic circulation, which is likely due to the migration of the T cell, and then an expansion of T cell population to like about 2 to 3 times of the baseline. So this actually tracks with the time varying clearance in the PK for BiTE TCEs. And also, we have observed the correlation of a lower CD3 binding affinity to relatively longer half-life and shorter clearance in the elimination of the drug. So that's the reason the CD3 receptors are included as a primary target for TMDD. And the model also allows for like adaptation to the specific tumor antigen targets. A feature that we are currently working on but haven't included is like, for example, for the time varying clearance drug, for example, CD20 targeted BiTE TCEs, we have observed this time-dependent clearance after repeat dosing. So that will be the next direction of including that part to for some of the BiTE TCEs. So another pathway we have considered is this renal filtration pathway. This is mainly for the 1st generation of BiTE TCEs, for example, the Blincyto. Like they have relatively lower molecular weight, around 55 kD, less than the considered cutoff of the renal filtration clearance. So we have included this pathway for these lower molecular weight modalities. And another pathway is this additional systemic clearance, which we use to account for the additional whole body protein turnover after you administer the drug to the patients. So these are the major pathways we have considered. So this slide is a summary of the key model parameters for the base adult model. I have cropped this slide from the published manuscript where you can find more details. And this slide I'm showing model validation. So this is mainly in adults. And in the top row, I'm showing an example for predicted versus observed PK plots. Left side, I'm showing the through IV dosing of a third generation BiTCEs, and right side, I'm showing a first generation BiTCE following SC dosing. So you can see that the model can relatively accurately predict the PK of these two modalities after dosing. So we further went ahead to include the 8 structurally different BiTCEs across the 3 generations of molecule for both IV and SC dosing, and adapted the model to incorporate admin properties of these different BiTCE modalities and further this validation. The bottom showing the observed versus the predicted PK parameters, Cmax and AUC. You can see that the predicted numbers are always in the twofold range of the observed data. So this further indicate the accuracy for the model prediction, at least for the adult part of the model. So next step, we went ahead and did another layer of exercise. So in this, we have we simulated the renal impairment patients with mild moderate renal impairment, and for first generation of BiTCE. So for this specific BiTCE, we have observed around 36% reduction in the clinic in the total clearance for mild to moderate renal impairment patients. And you can see that we were able to simulate this predicted this around 36% reduction fairly well. So this further supports the validity of the current model, and also taken together like model prediction as well as the clinical data. This actually indicates lack of need for dose adjustment in the mild to moderate renal impairment patients. So this is an exercise of showing you how we can use this model to support the clinical pharmacology strategy during the drug development. So next step, we moved to the pediatric prediction. So for pediatric prediction, in this slide, I'm showing some key ontogeny processes that we have considered for the developing this platform model. So I have broken down it into the absorption, distribution, metabolism, and excretion. So for general therapeutic protein, for its absorption, clinically, we have observed relatively faster absorption rates and similar, or for some therapeutic proteins, even higher, slightly higher bioavailability in pediatrics compared to adults. And in terms of the physiological changes that contributes to this, we have observed increased body weight normalized lymph flow rate. We don't have, as far as I know, we don't have the human pediatric data for this part. But from the animal, for example, the lamb, the puppies, we have observed around 2 to 3 times of the body weight normalized lymph flow rate compared to adults. And another thing we have considered is the SC depot size. So basically, after you inject the drug into the SC fat layer, how big your SC depot will be. So because the children, they usually have a relatively thinner subcutaneous fat layer compared to adults, this part can also impact the SC depot size. In terms of the distribution, clinically, we have observed a higher body weight normalized volume of distribution in pediatrics compared to adults. And this can be attributed to the relatively higher extracellular water in the pediatric subjects. As we all know that large molecules, because of their large molecular weight, their distribution are mainly restricted within the extracellular space. So higher percentage of extracellular water will make the drug tends to distribute to the tissues. And also literature have reported a relatively higher extravasation rates in the pediatrics compared to adults. Basically, the drug is more tended to distribute to the interstitial space through convection and passive diffusion. And also in this specific model, we have included this FcRn ontogeny, and this is from a published manuscript from Certara. And in terms of metabolism and excretion, clinically, we have observed higher body weight normalized clearance in the pediatrics than adults. So in terms of physiological process, it is suspected that this is likely due to an increased relative catabolism rate in the pediatrics. So we have, like from the literature, we have understood that in the pediatric subjects, their total whole body protein turnover rate can be relatively higher compared to adults, especially in the relatively lower birth weight pediatric subjects. Their protein turnover rates in terms of gram per kilogram per day can be around 2 to 3 times of what's have been observed in the healthy adults. So this part could have contributed to the relatively faster clearance in the pediatrics. And in terms of the TMDD, this is something like modality specific. So when developing this model, we have also considered for example, the ontogeny of the CD3 receptors in the pediatric subjects, and we have included that in the model development. And also, obviously, renal impairment, renal elimination ontogeny can impact that, especially for the first generation of bi-TCEs. So this is overall like for a general map the actual ontogeny processes we have considered. And in terms when developing the model, we have utilized 2 sets of information. The first set of information is from the sensitive general pediatric ontogeny database, which have already included, for example, composition, extracellular water, those ontogeny parameters. And another set of information we included is specifically for MAP or for bispecific T-cell engagers. For example, the CD3 target expression. So this part of ontogeny, it has been reported in the literature that the absolute T lymphocyte count can be relatively higher in the pediatric subjects, especially for the subjects under 2 years old compared to adults. So this part of the ontogeny we have included in the model, and also in 2 models, SC dosing, we have included this SC fat layer influence on the drug diffusion as localized C depot, and also some other parameters we were able to modify and to include in the model. So this is part of the model validation. What I'm showing here is for our first generation of bi-TCE. We have the clinical data for 1 month to less than 2 years old subjects, 2 to 11 years old, and 12 to 17 years old subjects. The red dots you're looking at on these plots are the clinical observed data set for these pediatric age groups. And the solid lines are the simulated, the model predicted PK profile. So for this one, the reason you're seeing this plateau is because this drug is dosed through intravenous through continuous IV infusion. So as you can see that the model, once we incorporate the ontogeny parameters, are relatively accurate predicting the clinically observed PK profiles in the pediatric age groups. So this further increased our confidence for this model prediction. And then we further included the SC dosing in the slide. So, and the model predicted, you can see, so these pediatric age groups were dosed with the same flat dosing of the same dosing regimen. So that's the reason their Cmax and AUC in the pediatric subjects are much higher. And the model predicted relatively like similar bioavailability in the pediatric subjects, maybe slightly higher, and relatively shorter Tmax in these patients compared to the adults. So this suggests a need for dose adjustments, especially for the young children. We may need to go with body weight or body surface area, like normalize the dosing regimen. We currently don't have clinical data to help validate this part of the model. However, these model predictions were supported by the clinically observed data in the literature of various age groups for the general map. So in the manuscript, I have used a table to summarize what we are generally observing for therapeutic proteins for the Tmax and bioavailability. So the model prediction aligns with the general observation for a map. So once we have clinical data, we will further validate this part of the model. So to summarize what I have showed you today, this is a novel mechanistic PBPK platform model that we have developed and validated for all the 3 generations of BiTCEs to help guide the dosing strategy for both adults and pediatrics, IV and SC administration. And we have also done the exercise of using this model to support organ impairment assessment. And this work highlights this novel mechanistic model for accurately predicting the PK in adults and pediatrics. And we are planning to use this model to help guide the optimal dose and dosing regimen design and accelerate the clinical development for the in-house BiTCEs. So that's all I have for today. I'm ready for any questions.
Thank you. There's a hand I can see from Armin. Did you want to unmute yourself and ask your question?
Yes, thank you. Thank you very much. It's always good to hear a good presentation, fascinating from the author of the work. Just to check a few details. How did you describe interaction with CD3? What was the affinity, for example? What was the CD3 receptor occupancy? How much did this contribute to overall extra elimination of the drug? And what about the other target? Obviously that BiTEs cross-link with and the cross-linking reaction itself.
Yeah, thank you for the question. So for the modeling the CD3 part, for the individual BiTEs, we have the CD3 binding affinity tested reported from the SPR assay, and then the CD3 receptor abundance we were collected from the literature and converted to Rmax, which is a receptor abundance term in micromolar of different organs. There are 4 specific organs we have considered where like most of the T cells are residing. So the blood, lymph, and bone marrow and spleen. And then it is assumed that once the drug are present in these organs, they will go through the CD3 mediated TMDD. So in terms of how much this pathway is contributing to the elimination pathway, it's different for different modalities. So like, for example, for the first generation, it's actually contributing to a very small amount of the total clearance of the drug, because for first generation, most of the drug are actually eliminated through the non-specific catabolic pathway. And for a second and third generation, it is contributing, especially for the third generation, based on sensitivity analysis. If you decrease the CD3 binding affinity to like around 1,000 fold, it's prolonging the half-life to about 3-fold of like beginning. So it is contributing a fairly amount to the elimination pathway for especially the second and third generation. And in terms of the other targets, the tumor antigen targets, so currently the model, it's also modality specific thing. So the model includes both the BiTCEs for solid tumor as well as for liquid tumor targets. For solid tumor targets, it's contributing to a very, very small amount. But for liquid tumor targets, like I said, we are still trying to incorporate that part, because in the clinic, especially for CD20 target, we have observed like a likely tumor antigen mediated TMDD, because like once you dose the drug with repeated dosing, you're observing this like decrease of the total clearance, which tracks with the B cell depletion, which we have observed. So that part, we're suspecting that the tumor antigen target is contributing a lot, like to a fairly amount. So that part we are still trying to work on to include into the model.
Right, thank you. How did you handle the cross-linking reaction, where a BiTE antibody cross-links target cell with CD3 with T cell?
Sorry, cross-linking of this.
Yes, with a target on the tumor cell with the CD3 on the T cell. There is obviously a ternary complex with target with BiTE between and then going to CD3. How did you handle the kinetics of that reaction, please?
Yeah, so for that part, like we're either using, like for solid tumor, or liquid tumor, we're either using the binding with only CD3, so that will be assumed that you only have the CD3 as a target for elimination, and once the drug, you can see that once the drug binds to the CD3 receptors on the T cells, then it will trigger this internalization of the drug, and then the drug will get eliminated through that way. And for like when we consider for bispecific antibody, like since they also have the structure for including this binding pathway, basically the drug can either binds to the T cell or binds to the tumor cell against internalized, or it can form this trimer, we already know a trimer, and then this will also trigger the drug internalization either through the T cell or through the tumor cell that way.
Right, and what kind of kinetic parameters would you use for the trimer formation, for example?
We basically only have the most of the parameters are from CD3 T cells. Internalization of the CD3 T cell drug, CD3 receptor drug complex, those set of parameters we collected from the literature, and we also have the data from in-house. And for the and also from for the tumor cell, it's actually assumed to be very similar to the CD3 binding internalization, because we don't have the parameters tested currently.
All right. Just one final question. Did you calculate the receptor occupancy for CD3, please?
Receptor occupancy? No, yes. That will be that's the next step we are planning. It's more for PD, connecting the PPK2 PD. So currently we don't have that part considering the model.
Okay, thank you very much indeed.
Thank you.
Much work. Congratulations.
Thank you. The next person is Tanvi. Do you want to unmute yourself to ask a question?
Yeah, hi. Very nice presentation. So I had a question about the CD3 internalization rate. Was this rate measured, or how did you do any experiments to measure this rate? How did you derive at that?
Yeah, there is a manuscript published in the literature. I have cited in the paper. So basically in that manuscript, they have measured once the drug binds to the CD3 receptors, and how what's the rate of internalization. So that's a number that we collected from the literature.
And the second question, Jamin, is you mentioned that the infiltration of CD3 or T cell increases, right, upon binding. Was this an observed phenomenon that you observed, that binding of the bispecific led to increased T cell in the tumor site?
So we have to consider this question like for solid tumor or for liquid tumor, right? Actually, from our internal data sets and also from the literature, we have observed this CD3 T cell dynamic for most of the bi TCEs. So and the data are mostly coming from the plasma or the blood. So basically, after you dose the patient with T cell with by TCE, and you will observe this transient decrease of the T cell counts in the plasma, and that hypothesis we have is that it's because the T cell migration into the out of the blood, and then right after that we will observe this expansion of T cell, like reach back to baseline, and also sometimes go even above the baseline to like 2 to 3 times of what we have observed in the baseline. So this T cell dynamic we have observed in the clinic, actually for both liquid and solid tumor targeted by TCEs. So in terms of the local, I'm sure I think your question is the local for solid tumor. The local site T cell concentration, that we currently we currently don't have like good data for that. So like maybe in the future we'll have some data. Like I will get access to those data. Yeah.
Yeah. Thank you very much.
Great, thanks. The next person who's got a question is Buyen. You're a bit quiet. Can you hear me? It's a bit quiet. If you're able to get any closer to the mic or increase the volume, that'd be great. Better now? Not for me, but I don't know if someone can hear better.
It will be more helpful if you can like
If you get quiet.
How about now?
Yeah.
Yeah, much better.
That's great.
Okay, great. Thank you. Very nice presentation. As a follow-up question to the previous scientists who asked about the tissue, the T cell migration to tissue, do you think the bispecific follows it into the tissue, or actually the KD to CD3 usually is high, it will dissociate?
That's this so like the T cell migration is a hypothesis that we are currently having. So I'm not sure about the T cell dissociate part. So
I mean,
it does
whether the bispecific in T cell engager will dissociate from T cell if T cell migrates into the tissue.
So I think the actual mechanism is that once you dose with the BiTC, it will actually triggers the drug like migration, and the migrated CD3 T cells may not necessarily be the like connected to the BiTE.
Okay.
It may have already been like dissociated, or like the mechanism is actually unclear. Yeah.
Okay, I see. And also, I'm curious because I think Blincyto is one of the pioneers. It designed in a way that the CD19 KD is much lower than the CD3 KD. And a lot of other bispecific ensued are designed in a similar way. So if you're thinking about the first dose before it depletes all the B cells, actually both the target will determine
Sorry, we lost you during that.
Oh, can you hear me now? Hello?
Yes. Yeah.
Oh. Okay.
Would it be possible
did you lose me?
Yeah, keep losing. Do you want to type your question? Would that be easier? Or you could just try one more time. Try one more time first.
Can you hear me okay now?
Yeah.
Yeah.
Okay.
Yeah.
So my question is, for a lot of molecules that's similar to Blincyto, the CD3 KD is much higher than the tumor targeting KD. And for the first dose, where both targets are pretty abundant, and we know that the KD is down to the T cell, do you think if we're mainly concerning about the CD3 binding, will we be missing some of the, especially cytokine release in the first dose?
Yeah, so first of all, currently, if I understand the question correctly, so currently for the cytokine release syndrome, it is considered to be mainly related to the CD3 binding, that part. So like, and also clinically, we have observed that if you decrease the CD3 binding affinity, it actually reduces the cytokine release syndrome. So it's more of a CD3 effect. And in terms of the first dosing, so yes, it is a concern. Like if you only consider the CD3 as a primary target and don't consider the, for example, the CD19, especially after the first dosing. However, from the what we have observed, the clinical model, we're trying to include this time varying clearance factor, and that's actually not playing a very large role. So basically the PK for the drug after the first dose or after repeated dosing is actually very similar to clearance. So at least for Blincyto, it's not like a major concern. And also I think this is more of a modality specific thing, right? For some of the modalities, we are not observing that time varying thing, like indicating a major role for the tumor antigen targets, especially on the B cell ones. For some of the other modalities, we are actually observing that. Decreasing total clearance as you repeat dosing. So we are actually observing that time varying clearance factor for some of the modalities. So for those modalities, I think specifically we need to consider this tumor antigen target, this pathway. And for some modalities, it's actually not playing a major role.
Okay. One last question, both for you and for Simcyp. Will this model be shared in the Simcyp members area?
It's the model has been published with the key parameters. You can find it from the manuscript below. The model itself, I don't think it's shared with Simcyp.
Okay, I see. Thank you.
Masood, I saw you were going to speak, but
yes, thanks. I thought to beyond question, obviously the biospecific, the structure model, it is already available in the simulator, but not specific to the compounds. So the structure is there from that side. My question was that you guys use a full PBPK model, and there are some kind of philosophical question about whether do we need to use the full PBPK model for biologics or even for biospecifics, or a minimal PBPK would be enough. What is your perspective on that question? It would be good to get your view.
Yeah, so for this exercise, the reason we use the full PBPK model structure is, first of all, I have included the CD3 as primary target. So want to define the primary organs that have the most abundant CD3 T cell. So that can only be done through the full PBPK model structure. And another thing is we're also planning to collect this platform model to PD. It depends on the modality. We will need the full PBPK model structure so we can specify the key organ or even include additional tumor compartment to the model. So that's the reason we're developing this using a full PBPK model structure.
Okay, thank you very much. And for the PD, you mentioned a couple of times that the next step, you are moving to PD, which is the natural progression from this one. Have you considered to use the Simcyp designer for that? Because by having the Simcyp designer, it will be relatively easy to connect to any even QSP model. I don't know what is your plan for the future.
Yeah, that's something I should consider. Yeah, thanks so much. Yeah, I'm actually planning to connect with Simcyp because Simcyp have been helping us a lot during this model development. Like in the next step, we may connect with Simcyp and use the Simcyp designer to do that.
Okay. Yes, thank you. Thanks very much for the presentation. It was very nice. Thank you.
Thank you.
Dan, you have a question?
Yeah, can you hear me?
Yep.
Yeah.
Yep, thanks. Yeah, really nice presentation. Thank you. The slide you were showing the simulated versus observed data for the renal impairment, and actually just looking at the area of the healthy at that level, the variability in clearance I don't think was quite well captured. Yeah, this one here. So you had quite wide observed variability of clearance, but your simulations seem to be quite narrow. Is that something that's quite common to the bispecific models or to this compound, and any reason for that? Is that of concern at all?
Yes. So I'm also like for specific programs, usually we have a population PK model and we have a PPK model. And my experience is that PPK model usually cannot capture the observed variability, especially for bites, very well. Part of it is because that we are not top-down approach. And for a lot of the parameters, the key parameters, we actually don't know what's the variability. Like in a real patient, it's like is. So the PPK model usually does not capture the variability very well. And especially for bispecific T-cell engager, the first generation, we have observed this very high variability in the clinical PK data. And part of it is because, these drugs are dosed through continuous IV infusion where patient carry this device. So the dosing itself could also contributing to a lot of the variability that we have observed. So it's a very complicated thing. I'm trying to understand where the variability comes from, but we don't have enough data, and we only have some hypothesis that this may come from dosing and this may come from the drug elimination or something. So it's very hard to adapt the PPK model to capture the variability correctly. So so that is a concern, and it's something that we're still trying to understand and improving the model.
Great. I can't see any more questions coming through. So I'd just like to thank Xingwen again for a really engaging presentation and a great period of questions at the end. I think there's a significant interest in your work. So thanks again for presenting today.
Thank you.
Our next one has been slightly rearranged to September. It's going to be Dr. Mingliang Tang, from the FDA, from the Office of Generic Drugs. This one is focusing on PPIs and the PH-DDI effect, omeprazole and nifedipine. So that will be obviously for registering on the same members area later after the summer break, basically. So thanks again, everyone, for joining today, and I'll see you next time. Thank you. Bye.
Thank you.